Thanks, Parveen, and thanks to Chris and Kristen for organizing such a great conference again. And nothing like a cornea conference to start coffee and bagels with a juicy corneal ulcer picture. But the use of steroids in corneal ulcers has really been a long time debate. There's a quote from Sorsby back in 1960 that to combine steroids with antibiotics is to convert two useful agents into one bad compound and to indulge in blunderbuss therapy of a particularly objectionable type. Probably British accent does that a little more service. But when you look at modern-day cornea specialists, just as the survey that we just did showed, there's an overwhelming majority of specialists, the Cornea Society and OMIG, and then today's studies show that definitely over two-thirds of physicians use steroids in this setting. And even the 2011 preferred practice pattern by the AAO, and Dr. Cohen spearheaded this, also recommends or suggests the use of steroids in certain ulcer settings. So where does this debate come from? Well, when you think about corneal ulcers, there's really a two-prong attack to the cornea. One is the actual destruction from the bacteria itself, proteases, endotoxins, and collagenases. And then the host attack that's trying to control the infection actually causes significant destruction as well. So it's not surprising that steroids that have so many anti-inflammatory properties are thought to be used in this setting. So steroids are known to be leukocyte inhibitors, matrix metalloproteinase inhibitors. They downregulate these pro-inflammatory cytokines. They also decrease vascular permeability and neovascularization. So it's not surprising when we think about cornea healing, we would use antibiotics to eliminate infection and steroids to control the inflammation. Well, why not use steroids if they can help in all these settings? Well, there's been shown to be decreased efficacy of antibiotics in the setting of steroids, delayed epithelialization, reduced host inflammatory response, increased risk of perforation, and a study out of Wills showed an increased risk of penetrating keratoplasty. And also, certainly a significant concern is the danger in non-bacterial infections, fungus, parasitic like acanthamoeba, and HSV. So what is the evidence? When we debate these questions, we always like to look at the evidence. So Wilhelmus did a meta-analysis study looking at all published studies on steroids and corneal ulcers from 1950 to 2000. This was published in 2002. So looking at animal models in studies, there are about 24 studies of different animal models. Typically, most of these studies had inoculation and concomitant use of corticosteroids with antibiotics given within about 48 hours of initial inoculation. And different outcome measurements were looked at. Essentially, 50% of these studies showed neutral changes. About 38% were beneficial, 13% were adverse. So again, inconclusive evidence when you're looking at animal models. What about the meta-analysis of human models? So there was some evidence that starting steroids prior to a diagnosis or before any use of antibiotics actually was detrimental in eyes. But again, the effect of steroids with antibiotics after the onset of keratitis was unclear. So again, available clinical reports cannot reliably conclude how steroids affect the outcome. So even looking at studies over 50 years' time, the data for meta-analysis was still inconclusive. So when we talk about evidence, we always want to look at randomized controlled trials. So what about randomized controlled trials? Well, one study was done in 1990 by Carmichael, and this looked at 40 eyes in which subconjunctival and topical fortified antibiotics were given. And then dexamethasone was added after 24 hours. Now, there was a lot of discretion on the physician's part here that if there was a deterioration in the clinical appearance, they may not be added or they may. And if there was no deterioration in appearance, they would add a steroid. The outcomes for this showed no detrimental effect between steroids and control. Both arms had improved visual acuity, but again, no statistical difference between the two groups. Now, the study was flawed for many different reasons, and actually about half of the patients in each of those arms was excluded after complications or change in the management. So still, coming to the 21st century, we really still have no specific evidence on whether steroids are effective or not in ulcers. So in comes the Steroids for Corneal Ulcer trial, which is an NEI-sponsored trial that was finally powered well enough that they were going to have significant evidence to show whether steroids were beneficial or not. And I meant it's an NEI-sponsored study, but I'll talk about it later. About 97% of the patients were from Aravind Eye Hospital in India, so very few patients from the U.S. enrolled in this study. And what the study included was 500 patients who were culture positive for bacterial ulcers. So they all grew. We'll talk about the specific type of bacteria in a little bit, but all of them had positive culture. So fungus, parasitic, viral, all excluded from this study. All the patients were given 48 hours of moxifloxacin hourly, and then every 2 hours until reepithelialization, and then QID for 3 weeks. Now, there was some discretion of the physician where they could change or add antibiotics at any time. And then the two differences between the arms of the studies is that at 48 hours, so after 48 hours of hourly moxifloxacin, half the patients were given predphosphate taper and half the patients were given placebo. The main outcome measures, primary outcome measure was best corrective vision at 3 months. And they also looked at best corrective vision at 3 weeks, infiltrate scar size at 3 weeks and 3 months, and the rate of adverse events, including perforation, and the time to reepithelialization. So what were the results of the SCUT study? So again, at 3 months, there was no difference between the two arms as far as best corrective visual acuity. The steroid arm had slightly better logMAR acuity at 3 weeks' time, but this was not statistically significant. There was no difference in the infiltrate or scar size at 3 months or at 3 weeks. There was no difference in the number of perforations. And interestingly, more patients in the placebo arm had elevated pressure, 25 less than 35. If we look a little bit more closely at epithelialization, which is always a concern, I think the audience response today was to delay steroid use until epithelialization had occurred. So the original pilot study was published, and it showed that patients in the steroid arm had epithelial defects at 3 weeks. But when it was looked at and extended till 3 months, this was not statistically significant. There was a trend for a longer delay in epithelial healing time, so 7 days in the placebo arm versus 7.5 days in the steroid arm. But again, this was not statistically significant. Now, some of these were all predetermined subgroup analysis. So these weren't things that were fished out after the data came out, but these were predetermined subgroup analysis that occurred. And this is when some of the interesting results came out of SCUT. And we were looking at bad ulcers. So patients that had a baseline correction of count fingers or worse, had completely covering the central 4 millimeters of the pupil, or had deepest infiltrate at baseline. All of these patients ended up having steroids, had better acuity. So these cases of bad ulcers, and in the SCUT trial, people commented on this and said that these suggest that patients with severe ulcers who may have the most to gain in terms of visual acuity may benefit the most from adjunctive therapy. And of interest, this is certainly the group that we had kind of feared the most in using steroids. Another subgroup analysis is looking at Pseudomonas. Pseudomonas historically had been one of the bugs that we feared using steroids in because of a theoretical increased risk of perforation and maybe decreased effectivity of antibiotics. But again, there was no significant difference in best corrective vision, adverse events, reepithelialization between the steroid and the placebo arm. And one interesting finding was that these patients actually responded better to treatment than other bacterial ulcers. So the Pseudomonas patients fared better than many of the other bugs. They had about 1.5 lines greater improvement in visual acuity at presentation. And this was controlled for even to the ulcer enrollment characteristics. Another subgroup analysis looked at susceptibility to antibiotics, and certainly this was not surprising. The rate, I did mention that although all the patients received the same antibiotics for the first 48 hours, the physicians could change or add antibiotics after that time, and the rate of change of antibiotics was about 15% in both arms, so it was equal in both the placebo and the steroid arm. But in patients that had a twofold increase in MIC, so patients that had less susceptibility to moxifloxacin, they ended up doing worse. So they had a decrease in visual acuity, larger infiltrate scar size, and slower time to reepithelialization. So does this study apply to the patients that we see every day in our office? I already mentioned that even though it was an NEI-sponsored study, 97% of these patients were from Erevan. And of those patients, a significant amount were agricultural workers, and only 2% were contact lens wearers, whereas probably in our office it's about the opposite, whereas 98% are contact lens wearers, 2% agricultural workers. The bugs were slightly different in that Strep pneumoniae nocardia was a very common cultured bug, and Pseudomonas, whereas in the States we usually see staph, coag-negative staph, and Pseudomonas. And then, do we treat these patients differently? If someone comes in with a severe ulcer, it would be unlikely that we would start them on topical moxifloxacin. More likely, we would start them on fortified antibiotics. And will we use predphosphate or possibly predacetate or loteprednol in our patients? So, after this study, the conclusions basically showed that there was no benefit with steroid use in culture-positive bacterial ulcers. However, there was no increased risk, no risk of perforations in the culture-positive bacterial ulcers. However, specific subsets may benefit from steroids, and most interestingly were the worst, those, quote, bad ulcers, so large central ulcers. And specific subsets may worsen from steroids. We know this as far as misdiagnosed fungal or parasitic ulcers. And then another important subset showed that, not surprisingly, microbial coverage with appropriate antibiotics is a critical factor in outcome. Thank you.